I wanted just to share the agenda with everyone so you can see how we're going to be doing this today. I was trying to put this in the chat. For some reason, I can't put it in there. So I'll just share my screen real quickly. So this is the agenda for today. I'm gonna do a brief introduction and talk about the issues we're facing, but then we're going to intersperse these with some video testimonies. We have some very moving testimonials from some of our clients that we at Disability Rights Texas has worked with. And then as you can see through the agenda, they're going to have Jessica Boston will speak from Texas Association for Home Care and Hospice. We'll have another video testimonial from, then we'll have the perspective of the private providers for HCS services from Carol Smith, the Executive Director of the Private Providers Associations of Texas. And then we're going to hear from Kristen Robinson, the VP of Governmental Affairs of Angels of Care Pediatric Home Health, about access to care and wage disparities. And then we're going to hear from Nancy Crowther of ADAPT of Texas to talk about the lack of attendance services. And then we'll have one more short video testimonial from one of our clients where they've recorded these, so you can hear, put a face on this from the persons that are actually experiencing these issues. And then we'll just have a open discussion, hopefully for about 30 minutes, where we can talk about the issues in an open format. Let me introduce myself for those who don't know me. My name is Sean Jackson. I'm the Executive Director for Disability Rights Texas. And prior to my taking that position, which I was fortunate enough to have the honor of doing, in April, I was over our community integration and healthcare team for disability rights. So in that capacity, I did a lot of work with persons on Medicaid waivers, persons who were trying to navigate the system as far as getting attendance services, nursing services. So this is an issue very dear to my heart, close to my heart, I should say. One of the things that we have seen at Disability Rights Texas over the years is that it's always a moving target. The original issue was dealing with, and it's still an issue, the underfunding of services, which applies to this too. But one of the issues was that we would generally have someone that we were fighting to get more services. So if the doctor said they needed 60 hours a week of attendant care or 40 hours of nursing, the argument was, can we get that authorized? Since the pandemic, and it hasn't abated, the new issue now is, even when the services are authorized, we are having an inability to get attendants or nurses to work the services. When we're talking to our clients, they just do not have enough help. This is providing a ton of issues, obviously, as you can imagine. And just one statistic I want to share with you. I know we're going to talk quite a bit about rates, but it's even more than that. The U.S. Bureau of Labor Statistics is estimating that 500,000 nurses were going to leave the profession this year alone. That's already exacerbating a nursing shortage that has existed for years, of over 1 million. It's going to make the shortage now go over 1 million in the continuum of care. At some point, I've thought of calling this a health emergency, but I'm going to call it a crisis. I hesitate to call it an emergency because it's been an emergency that's been over a decade in the making. That pandemic has, again, exacerbated pre-existing issues, and it's really impacting our clients. What we want to do is put the focus today on, we've heard a lot about hospitals, we've heard a lot about nursing homes, assisted livings, whatnot, institutional settings, and them not having enough workers or nurses or attendants or other healthcare workers. We are focusing today on persons who are receiving in-home services in the community, for instance, on waivers and things of that nature. That is a crisis, in our opinion. and it is one that is growing. So our objectives today is to learn from one another. I always tell my team, I don't know. I don't try to give answers till I know the questions. I don't know that we know all of why this is happening. It's easy for us just to say it's rates. Maybe it is, but I'm thinking maybe more than that. I think there's a burnout factor. Folks are leaving the profession. There's other economic factors. But we also want to raise awareness about this issue. And finally, we would like to come together to talk about how we can collaborate to perhaps make some policy recommendations to policymakers for some realistic solutions to these issues. I just saw a question, are these services primarily provided through Star Plus? That's one of the ways, Star Plus waiver, but there's also other waivers. There's the class waiver. There is the MDCP. There is Texas Health Steps, Children's Medicaid. There's a variety of these services that are breaking down in the community. HCS is a huge one where we're breaking down. So without further ado, I'm 2 minutes over, so I apologize and try to keep to the schedule. Laura, could you queue up our first video testimonial? And that will be from, hold on one second. That will be from Terry and Lily Magrin's Courtney. Go ahead, Laura. This is one of our clients. We don't have sound.
Hi, I'm Terry Bronze Courtney, and I am Lily Courtney's mom. She is 11 years old and has been diagnosed with a very rare form of mitochondrial disease, ATP. She has a variant of ATP51A, and she's also been diagnosed with spastic quadriplegic cerebral palsy, dystonia, congenital adrenal hyperplasia. Lily, can you smile for me? There you go. There you go. So I'm just going to put her in her chair for just a second, and then we'll get started. She was approved for MDCP after being on a waiting list for several years. We had it for 2 years, and then our nurse, when COVID hit, our nurse went to work for a COVID clinic, which she was making at least 3 times more. And so at that point, it was brand new COVID. And so everything shut down, and we had an extreme shortage of nurses. We didn't have a lot of information about COVID. And so we went about 1.5 years without a nurse. And every time I would call the nursing company, they just didn't have any nurses to staff, and because of the shortage. And then in November of last year, we were able to find a nurse, and we started nursing at that point. It was worse than difficult. I'm educated, but I have no training in medicine and nursing. And so we went into survival mode, my husband and I. We also have 2 other children. Lily has a twin sister, and our son is 15. And so my husband and I, we both also work, and my husband and I went into survival mode. So every 2 hours, we would take turns nightly on the night shift to make sure that she was breathing, to make sure she was repositioned, to make sure that she was getting her medicines on time, and to make sure her G-tube feed was working correctly. And so every other day, we took turns on the night shift. And so we turned into walking zombies, if that's even a description, because the care that she needed at night, I was also doing during the day, my husband would go to work, and thankfully I work from home, but it was nonstop. And there were so many, with all her diagnoses, there's so many things that I didn't know to check for. And every time I would call just out of desperation, the home health, they would tell me, we have other kids that we're trying to get staffed, we can't get staffed, there's a severe shortage. And at that point, we just felt so alone. Our two other children, they have needs that are equally as important as Lily's needs, even though they're typical, they don't have any special needs or diagnoses. And so we found ourselves having to prioritize which need are we going to take care of, which placed a tremendous amount of stress on and fatigue on our family and on our marriage. We got through it by the grace of God. To help her one time, I know she had an extreme ear infection, and we just brought her home and kept her comfortable. One time there was a lot of vomiting. We just prayed that please help us and give us, because we didn't have the support and the knowledge to know what to do.
Thank you, Laura. So again, we're going to intersperse these in a little bit just to keep a face on this, and make sure that we have the context of what we're dealing with. This is a extremely important issue, and it's again, I'm not going to call it an emergency because this has been building for years, but this is just horrific. Some of these stories that you're going to hear today from persons that we've worked with. I'm going to turn it over right now for about 10 minutes to Jessica Boston. She's the Director of Government Affairs for the Texas Association for Home Care and Hospice. And I think she's here also with Rachel Hammond, who's going to be, I think the ED, but she'll be sitting in. But Jessica, if you would share with us, again, if you could enlighten us on what you're seeing in that what your organization deals with, is you're one of the bigger organizations that deals with these particular issues.
Absolutely. Thank you for the warm welcome. And again, my name is Jessica Boston, and I'm with the Texas Association for Home Care and Hospice. And so for those that may not be familiar with the organization or maybe listening to a recording later, I just wanted a chance to sort of introduce where our member agencies are in this within the system. You know, our members provide PDN services as well as attendant and direct care services, kind of starting with a bit of a focus on nursing and the PDN services, especially since we just heard previously just that incredible video on what families are experiencing. And from the agency perspective, we're certainly, she certainly spoke the truth about what agencies are seeing and experiencing as well. You know, as we look specifically at PDN services, we're stuck in a dangerous loop of trying to keep up with, on the one hand, the need for services, and also trying to meet the demand for of the workforce shortage. There are absolutely not enough nurses to meet the need in the community. And when the patients, as we're talking about PDN, predominantly children, are unable to receive these services that they need, we find that they are then having to seek care in the hospital setting. And when this happens, not only our hospitals, and I happen to be in Austin, we find that our hospitals are having an increasingly difficult time meeting this need as well. So this loop that I'm referencing is that the children either are stuck at home in need of advanced care, or are actually stuck in hospitals ready for discharge, but the demand in the community is so great, they're not actually able to return home safely. So those are some of the things that we're seeing specifically as it relates to PDN and nursing, but we also provide attendant and direct care services as well. And so, we're acutely aware of the shortage in that area also, and impacting our members across the state, specifically kind of focusing on recruiting. It's very difficult to, we hear stories from our members talking about putting up job postings and receiving 0 responses. Or, if you do have those spots filled, that there is actually a 100% turnover. So as fast as you're able to train someone to come into this field and participate as an attendant or direct care worker, they're leaving again and again, sort of chasing that better pay. So, just to kind of center what we kind of kicked off the conversation, we're certainly aware and feel, as Sean mentioned, that significant sustainable rate increases are integral to the path forward. Certainly from our perspective, we've received some temporary rate increases and one-time grants, but this is simply unsustainable to really meet the needs and to have an impact on the workforce challenges that we're seeing, that our members are seeing, compounded by things like gas prices and inflation.
So Jessica, I have a question.
Yes,
Are you
sir.
seeing primarily the flat rates, but is there also an issue with less persons coming into the field or leaving it?
Yes,
More
absolutely.
leaving it, I should say. Yeah.
Yeah, absolutely. And I think some of this was also very present at the beginning of the pandemic, that many people were simply leaving the workforce altogether. So there was an initial wave that for those caregivers that were close to retirement or were able to move into another sector, there was an initial wave of that as the pandemic took hold. However, there has been also a continuation of that with burnout and people leaving the industry entirely. And when we're talking specifically about attendants and direct care workers, we're finding that we're not able to compete with other industries. People are leaving the industry altogether. So they're going into hospitality, they're going into food service. And so it's certainly both of those pieces that we're seeing.
Okay, thank you. I just see a note from Kathy Cranston in the chat. We're competing with $15 to $18 an hour on the free market. Attendants cannot sustain themselves or their families on a base wage of $8.11 or even $9 to $10 an hour.
Absolutely.
Okay. And
absolutely.
Jack, our attendant nurses, there's two different things. There's the attendants and the nurses. If you're talking about the nurses, there typically are licensed vocational nurses, LVNs, and they're supervised by RNs. But then there's just certain attendants that the term would be, common term might be certified nursing aide. I think it was what they would call them in the hospital. So that's a little bit different. Okay, Jessica, did you have anything you want to add? I didn't want to.
Well, and if you don't mind, I'd like to clarify a couple of things, because particularly about the nurses, as we're seeing some of the other challenges, again, they're moving into hospitals and higher paying jobs in hospitals and other areas of nursing. And as you know, the wages have been stagnant in home care for many, many, many years, both for nurses and for individuals who provide direct care services, regardless of whether or not that person is certified or working as an attendant without a certification. The wages have still been flat for many years. So, to Jessica's point, the private market has been able to adjust, but we're, as home care providers, reliant on the state for reimbursement, and that has been not been addressed for well over 16 years on the attendant side, and same thing for the nurses.
Okay, and that's Rachel Hammond, also with Texas Association of Home Care and Hospice. Thank you. Yeah, there's a lot, yeah, there's a lot going on here. And again, I don't think it's new. I just think it's gotten worse. But thank you for that information. Let's queue up, Laurel, can we queue up another video testimonial, Dave and Kate Chappell, not Dave Chappelle, Dave Chappell. This is a wonderful couple, married, that both have CP, and they have quite a story.
Hello, my name is Kate Chappell and I am from Austin. I live independently in my own house with husband David Chappell. We both have cerebral palsy, which affects our ability to do our activities of daily living. Over a month ago, when Dave and I did a DRTx, had an evening attendance to help us with dinner. I had no other option but to ask my 80-year-old dad and stepmother to come from Georgetown to bring us dinner and to feed us. The expectation of having them come every evening to help with dinner was not a reality. Our reality is we are solely dependent on our personal care attendants for our most basic care. We have been forced, due to the lack of attendance, to spend at least 4 or 5 hours alone. I am sitting in a diaper for 5 hours when I am continent, but there is no one to help me to the bathroom. In the past, in our meeting with our service coordinator, we have talked about having a roommate as backup. Since we are on the HCS waiver program, it doesn't allow someone living in our home to work for us. Other waiver programs allow house members to work for clients. I doubt you understand why this policy is not streamlined across all waivers. Having a roommate who can be a backup when we don't have anyone to come is crucial for our well-being.
Hello, this is David Chappell and I am on the HCS Attendant Care Waiver Program. I need my attendants around to fulfill my personal needs, such as assistance with the bathroom, drinking, and sometimes even driving me to a meeting. Also, if my morning attendant doesn't show up, I am stuck in bed until my evening attendant comes 8 hours later. The same holds true if my evening attendant doesn't come. I could need to sit in my wheelchair all night. It is a fact of my life that I am going to need attendance for as long as I am on this earth. It is because of this I need reliable attendants and people who can be reliable backups ready to step in for a moment's notice. For multiple reasons, my wife and I had a very difficult time actually hiring reliable attendants. We both are authorized to get 14 to 16 hours of care 7 days a week. There were several days for several weeks this summer I had no care at all for 6 hours straight. During those times I couldn't drink, eat, or go to the bathroom. There were times I had to sit in my own feces for hours until somebody came to clean me. It was disgusting and dehumanizing because I have the ability to control my bowels and bladder to tell people when I had to go to the bathroom. Lastly, I would like to add we are in the same situation when an attendant calls off due to illness or bad weather conditions. These situations are most often unexpected and unplanned, and I have to scramble to find coverage for my other attendants. However, if I can find anybody come, I am pretty much screwed, and once again, I'm not able to drink, eat, or go to the bathroom.
Thank you, Laura. I think the word that jumped out to me on that one was dehumanizing. Again, this is a crisis. And I want to go back to something that Rachel said earlier about that you're competing with hospitals. We know a lot of funding and resources during COVID-19 was directed to that particular setting because, you know, that's the broader community, and that's what people think of. I may go to a hospital. Just the public, I don't know if they really, if they don't have a disability or need an attendant or nurse, I don't know if they, in their home, I don't think they think of that as something that they may need, but we all know that we're one incident away or anything from being in this position. You can have a stroke, anything. So this applies to everybody. And I think, again, we need to put some emphasis on the community, because all I've heard about are institutions like hospitals, nursing homes and whatnot. And we want that too, make sure that's covered, but we're not seeing any energy around the community. And I know I'm preaching to the choir. You folks are the ones that are dealing with this on a daily basis, but it's just a problematic. So let's, I think it's really timely the way this is set up. Carol, I know we only have your audio, but Carol Smith is with Executive Director of the Private Providers Association of Texas, better known as PPAT, and they deal quite a bit with the HCS group settings and having persons who that their particular members serve. So Carol, if you could kind of give us your view of your perspective of what you're seeing in those settings.
Okay, can you hear me?
Yes, Carol, loud and clear.
Okay, great. Well, first of all, thank you for inviting me to this. I really appreciate the opportunity to provide at least our thoughts. I don't know that I have anything new or different to say than what you have already heard. We all across the board are experiencing unprecedented shortages, both in attendant or direct support staff and nursing. And Sean, as you pointed out in the beginning, this was already an issue prior to the public health emergency, and now it's just as a result of the PHE, it has, exasperated significantly. I will say that in January of this year, what we call the 3 IDD associations, which is the Texas Council of Community Services, the Providers Alliance for Community Services of Texas, and of course PPAT, conducted a survey of our respective memberships. And what we found was that 1 out of every 3 group homes in the HCS program at any given time doesn't have scheduled staff. 60% reported programs or services were discontinued due to high turnover and vacancies. And 91% reported difficulties meeting quality standards due to high turnover and vacancies. Based on just reports that I have received since that survey, I would venture to say that if we redid this survey, it would even show something even more dire than it did back in January. We have many of our owners and administrative staff are filling in, whether it's in a group home setting, but also in the setting that's now called Community First Choice Service, where a person's living at home with their family or in their own home. Many even though during the pandemic, and it's still available today, you can have a family member provide those attendant services. Many families, like others, have had to go back to work. And so it has been very challenging to find, staff in those situations. I've said this story several times. At least one of the PPAP members in the Houston area, the owner is actually doing the providing the day-to-day attendance services for one of a family who has opted to go back to work. And what does this result in? You all have already mentioned it. It places people at risk of institutionalization, jeopardizes their health and safety. It causes burnout for staff covering multiple shifts, increases opportunities for unintended consequences such as medication errors and other errors. It reduces the ability of providers to deliver needed services, increases provider reliability. And we have already had experienced situations where many providers have either, particularly for the group home settings, have either consolidated their homes or they now are just closing their homes. And that in and of itself causes problems because in many cases, if a person closes, their provider closes their group homes, where do those individuals go? Not all have families or the ability to opt for the host home setting. And other providers may not have vacancies or may not want to take on the liability due to their staffing shortages to accept an individual in their particular group home. And I know you didn't want to talk about institutional services or the community-based ICF program, but I would just like to say in those instances when a provider decides to shut their doors, those individuals in that home don't even have the option to even pursue, HCS services. So that complicates matters as well. And I just want to mention couple more things. Historically, providers of IDD services have always had to compete with state-supported living centers. And while I do not want to bash state-supported living centers, that's not my goal in stating this, but during the pandemic, I think 3 or 4 of the state-supported living centers who were experiencing extreme challenges were able to up the base wages that they were paying attendants that equated to around $15 an hour. Effective September 1st of this year, it was 3 or 4 more state-supported living centers received the funding and the authority to do the same thing. And that has only exacerbated challenges if you're a provider in an area where there's a state-supported living center to find staff. And then with regard to the enhanced FMAP or the ARPA dollars that a lot of the community-based programs were receiving, for HCS providers, this has been, first of all, it's just a Band-Aid, but because of changes in the way that providers now in the HCS program bill for services, many of the providers have had extreme difficulties in receiving funds. Some have not been paid for, close to half of the people that they serve since May 1st. So they're not only are they not receiving payment, they're not even receiving this enhanced FMAP. So there's the challenges we're facing.
No, that's very helpful, Carol. So you're just one takeaway I'm hearing is that this is going to have less placements in the community if it's already happening, I guess, right?
It already is happening, and I fear that it's probably even going to narrow more as time goes on if something is not done. So, and I would suspect that other providers, I see that Sandy's on the phone, I know Diane's on the phone, and I know she's the expert in nursing and will probably weigh in on nursing, but she's also a provider of services. And I'm assuming that she would ditto all of the challenges that I have described. But
right.
Yes, this is getting extremely challenging, and I wish people were listening, you know.
Right, so this won't just affect the folks in the waivers. This was affecting, I know we deal a lot with trying to get persons out of, like you said, state support living centers, nursing homes. A lot of them go into HCS, other waivers like that. And if there's not placement, so they're not going to get out. And then there's people
Exactly.
that go back in, right? No, yeah,
Exactly.
yeah.
Exactly. And, you know, I don't want to, you know, throw another issue with, particularly with regard to the group, the 3 and 4 bed group homes in HCS, are the property taxes too. Many providers cannot afford the, you know, the rising cost of that alone. And that as well as the staffing shortages and not being able to pay a higher wage rate to attract people, has complicated this matter. So, and then you have regulatory issues, because even though, you know, you're supposed to maintain compliance with all these standards, and there appears to be no recognition that people are struggling right now. So, you know, particularly with direct care staff who are working multiple hours of overtime, if you make an error, you know, that provider is subject to a citation and potentially an administrative penalty. And it just seems so unnecessary. I know there's, in egregious situations, citations, deficiencies need to be cited, but in some cases it's like, you know, we're just what's adding salt to the wound, or we're punishing people who are sitting there trying to do, you know, the day-to-day work that we can't get anyone else to do.
I see. Okay.
So it's heartbreaking.
Yeah. There's a couple of notes in the chat I want to address. Nurses are getting, this is from Bill Sapansky. I hope I'm saying your last name right, Bill. Nurses are getting $75 an hour on average in the hospital, where we can only pay $25 to $30 an hour. And then Amy was saying that she's has an interview for an attendant today. Hopefully, fingers crossed, hopefully that goes well for you. And then Linda Lissinger said, if you are forced to move into a nursing home, does Medicaid or Medicare then prevent you from going to your job or working it virtually? I would say no, but it's very difficult to work because a nursing home, there's transportation issues. And then you get into the question of whether or not you're disabled enough to really be in a nursing home. I've seen it happen, but I don't see it happen very often. So the answer to your question is, it becomes extremely difficult to maintain a job and be in a nursing home. It just causes different issues, but I have seen it happen very rarely.
Sean?
Yeah.
Yeah, Sean, this is Carol. If I may make one more comment, because I haven't heard anyone bring this up. We have quite a few providers that are using staffing agencies, if you will, to cover you know, nursing shortages and then even attendant care. And the cost of that is, you can only do it, well, if you're lucky enough to be able to do it, you can only do it for a very, very short time, because you cannot afford what those staffing agencies pay.
That's true.
And
They're more expensive. Yeah, I'm aware of that.
Exactly.
Yeah.
Okay. But no one had mentioned it, and I just thought I'd throw that out there.
Thank you for that. That's all of it. All of it helps paint the picture. Let's go to we'll turn it over to Kristen Robinson, RN, VP of Governmental Affairs, with Angels of Care Pediatric Home Health. And Kristen, I was looking at your website. I thought you guys were just Texas. It looks like you're bigger than Texas. You're regional,
Yes.
right? Yeah, okay.
We're in 7 states.
So
yes.
You can give us a perspective of Texas versus other places too while you're doing it. So I'm gonna turn it over to you. Thank you, Kristen.
Okay, no problem. I do have a PowerPoint that I recently shared with the State Medicaid Managed Care Advisory Committee Subcommittee on Network Adequacy and Access to Care. There's a really long committee name. So let me pull that up real quick to share that.
Yeah, we can see it. You're good.
Okay. And then I start here as a slideshow. Okay, so as you guys have been discussing, obviously what we're seeing is a multitude of issues. So one, we have the workforce shortage. We're still dealing with COVID in relation to positive cases, but also all the extra administrative activities that we have to do related to COVID. The huge wage disparities between hospitals, staffing agencies, travel nurses, and home care. And then of course, just the low reimbursement rate. A lot of the wages that we're being asked to provide to nurses is more than what we get reimbursed. And as a provider at Angels of Care, we do still provide community care services, attendant services, but very rarely. The only time that we typically do provide them at this point is if there is a family member that is wanting to serve as the attendant, because we are just not successful in going out and trying to recruit attendants. It just does not happen. I also want to just point out that looking at the private duty nursing industry and kind of the staffing utilization that we're seeing, so authorized hours versus billable hours or hours that are actually provided, depending on the area that the children live in, we're seeing anywhere from 40% utilization to maybe 65% utilization, whereas pre-COVID, it was anywhere from 80 to 95%. So it's a huge drop in utilization just since COVID hit. And obviously, as Rachel and Jessica stated, this has been ongoing for many, many years. We've always struggled to compete with hospitals when it comes to rates. And we tried to look back and see when the last time the LVN rate was actually addressed by the state, and we can't find it. We've gone back more than 30 years. And so the base LVN rate has been at $33 an hour for at least 30 years. So just goes to show how they have not addressed their wages. So just some of the suggestions that we think need to happen in the state is one, and this is something we are seeing in other states, is investing in nursing schools, higher salaries for instructors. Most of the instructors that we're seeing leave are leaving for these higher paying jobs in the hospitals or other areas of the nursing field. Incentives for clinical sites to allow more students. When you've got all of these hospitals that are trying to gain their magnet status, or they have that magnet status, we don't see them allowing these LVN clinical rotations to come through their doors. And with that, we also want to expand the clinical sites. So as of right now, for instance, home health is kind of excluded from that. We can have students come through and rotate, but they are not allowed to do any hands-on, even under the supervision of an RN. They are only there to observe. And so most students do not choose to come and do any clinical rotations through the home health setting, when again, more clinical sites are needed because they can't get hands-on. So that would be something that would need to be changed. Scholarship opportunities and grants for tuition to encourage more interest for nursing students to enter into the field of community care and home health. And then also investing in high school vocational programs. A couple decades ago, there were quite a few LVN programs available to high school students where they could graduate high school and at the same time come out with their LVN license. Again, there are fewer and fewer of those. Not sure the reasons, but something that we should be investing in. I would say that when we look at our percentage of LVNs to RNs in the home health industry, it's about 60% LVNs and 40% RNs. Again, depending on the area of the state. Also, ensuring an efficient and streamlined method for billing PPE. During COVID, the state came out and said that providers can bill for PPE. I am still not aware of any providers that have successfully been able to do so. They've kind of put it on the MCOs to manage how that works within each plan. And so that has become very difficult. And honestly, something that we just don't even, at this point, we haven't even tried to continue to do.
What we've seen for hospitals and other facilities is COVID add-ons for providers caring for COVID positive clients in their homes. Again, in home care, we haven't really received much support when it comes to COVID relief. Most of that support has gone to the hospitals and nursing homes. Whoops, I went backwards, sorry. So one of the big things we obviously have talked about is the reimbursement rates. We would love for HHSC to actually make a recommendation to the legislature to allocate the appropriate funds. I am not sure that they're doing that at this time. Something that we do see in other states is where they do a cost of living increase every 1 to 2 years, something that we would love to see Texas adopt. And then that way we're not going decades without having the rates addressed. We would like to see a study completed, and this could be part of that cost of living increase, whether it's every year or every 2 years, where a study is completed to analyze the wage disparities and the current rates, but also looking at what are the hospitals paying, what are the nursing homes paying, what are the home health agencies paying, and let's bring them to levels where it's competitive, and make recommendations based on that data. PDN definitely needs a rate increase. We know this, so does community care. What we've seen in the past, like I said, we went back to see where those rates have changed. It's all been policy. So in the early 2000s, we saw a differentiation between RN and LVN. And then we saw the addition of the UA modifier, which adds a differential for children who have trachs or vents. And so considered a specialized modifier, specialized service. And so then in 2011, we had a rate reduction of 2.5% for an expected budget shortfall that didn't happen. And it took us all the way to 2019 to finally get them to reinstate that. When you talk to the state, they're like, "Oh, we gave you a raise in 2019." Well, it was not a raise; it was a reinstatement of a previous rate cut. But one of the recommendations would potentially be that rate increase across the board. But since it seems that Texas likes to do policy change in regards to the rate, maybe there could be differentials. We do see this in other states, whether it's nights, weekends, holidays, and even overtime. Obviously, if we have the ability to pay overtime, and let's say we have a case that has 50 or 60 hours, a lot of times those families still just want one nurse, and that nurse is willing to work 50 hours in a week. But it makes it very difficult for us to be able to pay them a competitive wage when we're obviously mandated to pay time and a half for overtime. So it's one of those differentials that we do see in other states as well. And just to talk about rate increases and COVID relief in other states, every state that we are in did do rate increases throughout COVID, and also offered, whether it be bonuses or one-time payments. We did see that in every other state. Texas, we finally, got some of that, the ARPA funds allocated into the grant opportunity, which we still have not seen those funds. We just recently had the application process for the grant, and I'm not sure when that money is going to be released.
Kristen, do you ever see states do a differential based on geographic location within the state?
Yes, so there are some states that have rural rates and urban rates, and then states like Virginia, they have the basically the upper Virginia and then the rest of the state. So we do see that. The difficult part with Texas is that majority of the states are considered rural, so it would be hard to differentiate which parts of the state would get an add-on or not. And then honestly, right now, we've always had difficulty with rural areas, but we're also seeing a lot of difficulty in urban areas because they're closer to the hospitals, and those nurses are going to the hospital. They're not coming to home health. So it's kind of become just an overall issue across every region in Texas. So then, we start thinking think outside the box. Obviously, rates need to be addressed, but then let's say we are competitive with the hospitals. Well, hospitals are paying all this money and they're still having issues getting appropriate staff. So we know there's a workforce shortage. And so what we're seeing in other states, Colorado, for example, which has been doing it for decades, Arizona, that just rolled it out this year, is the family caregiver programs. In Colorado, it is the familial CNA program. And so they allow family members and honestly any CNA to provide delegated nursing services to those children. And I know there's a lot of fear in Texas just because we've been having these conversations for a while of MCOs trying to push that CNA model on families and taking away their PDN. But what we're seeing in these other states is it's really just expanding access to care. It's not a replacement, it's a supplement. And so what we really like is the model in Arizona, where they actually created the term licensed health aid, or LHA, and it's billed under the home health aid code. So it's delivered under the home health benefit in Arizona, and it is specifically for family members. And so it's a little bit different than Colorado, where it can, it's primarily family members, but they also allow other CNAs to provide the service as well. The LHA service is once you become a licensed health aide, you can only deliver that service to that specific child that you were trained and certified on and licensed. Your license is actually connected to their Medicaid number. So it's working really well in Arizona, even though it just kicked off. We're seeing great things. And again, there are I think 7 states across the US that either are doing this program or a modified version of this program. So an LHA, what's the difference and what differentiates an LHA from just paying a parent to provide the service? I think the video testimonial that we heard earlier, from that parent, she is not a trained nurse and she's not trained in the nursing tasks. And so what we're doing within the LHA program is actually educating on the medical benefit of what you're doing. And so we're giving them that educational piece to understand why you're doing it, not just how to do it. And so it is a higher level of training than just an unlicensed attendant. And in Arizona, they are required to pass a written test as well as a skills checkoff to receive their certification and obtain their license, which in Arizona is managed by the Board of Nursing. So obviously an attendant, they're required to have their high school diploma or GED. They have to pass the skills checkoff. We as nursing agencies, very, very rarely come across an attendant, again, unless it's a family member that we are comfortable delegating nursing tasks to. It's typically a revolving door. They stick around for a few weeks and then we're having to train somebody else. LHA wages, what we are seeing again in other states for these family caregiver programs is allowing us to pay $15 to $18 per hour, sometimes up to $20. Whereas attendant wages, as everyone knows, is typically $8 to $9.50 an hour. And I had already mentioned the RN and the family members being more comfortable delegating to someone who has been medically trained and certified. With LHAs or CNAs, they do tend to develop tenure, whereas, as I mentioned, attendants are typically out the door as soon as they find a higher paying job. It's not a career choice for them. So they're getting higher quality of care than that of an attendant. The continuity of care is there. Reducing hospitalizations. Bill Skapansky is on the call. He's with Team Select. They actually did a 2-year study of their clients in Colorado, where the hospitalization rate amongst their family CNA clients versus their PDN clients was significantly reduced. And we can get those exact numbers to you, but higher satisfaction, obviously, from clients, better outcomes, fewer negative events, and consistent delivery of medically necessary care. Again, with family members being the ones providing the care, they have a vested interest in the well-being of the child. We do see fewer errors and mistakes and incidents. No one knows the needs of a child better than their parent or caregiver or their family member. And in many instances on the PDN side of things, and parents that are on the call know this, y'all are the ones that are reinforcing training with the nurses in your own homes. So, you guys know what your child needs. And so with inconsistencies in the workforce, this program does allow parents to continue working. I can't tell you how many parents we have seen quit their jobs because they can't get consistent staffing or they get fired. And so they have to be home. They want to be working. They want to support their family. This allows them to do that. And then I'm trying to not go over my time either, but the way it works in Arizona is the provider agencies actually develop the LHA certification programs in line with what the Board of Nursing has as requirements for the program. We would like to see Texas actually have a standardized program for this training to ensure that all agencies are doing the same training across the board. And this is really important. So these services, again, are not intended to replace PDN. They are a supplement, and there needs to be, protections in place to ensure that families are not forced into this. This is a choice, not a requirement. And there are some kids that are too highly specialized for these services. It is up to a nurse to ultimately decide whether or not they're comfortable delegating a task to anyone. So we just want to make sure that whatever we do, those protections are in place. So we would like to see HHSC make recommendations to the legislature to include family caregiver services in their budget. It is a cost savings to the state. So for every nursing task that is delegated, obviously it does lower the need for PDN. So when you're paying for a lesser service, obviously the rate is lower and therefore costs the state less money. But it also helps with taxable income that's coming in for the state, the reduction of welfare that some of these families may be receiving. And again, making sure that there are protections in place so that this income does not in turn, make them ineligible for Medicaid. The other states have addressed that as well. So there are several providers in Texas that are providing this in the other states that are doing this, and would love to have a panel or further discussions around this solution as well. That's the end of my slides, but yeah, so this is something that has been shared with HHSC. I've presented it to a group of about 10 people from HHSC last month, including Dr. V, Dr. Glenn, Michelle Irwin, and several others. And then I was asked to present it to that subcommittee on network adequacy and access to care. Bill has presented this also to the governor's office on persons with disabilities as well, and they seem to be in favor of it. So there is a lot of work to be done, obviously, and it needs to be multifaceted. We can't just, throw a bunch of money out at it and expect it to be fixed. We have to address the nursing shortage as well. We have to expand the possibilities for other types of service providers. It's not just a simple solution.
Kristen, can I add a couple things?
Yes.
Hi, Bill Spanks with Team Select. Like Kristen, we're not only in Texas, but 10 other states. And we do have framework for this bill as well that we built out into what Kristen was saying. We do have protections that's built in to it. Again, it's not going to be for every child. And for everyone that's on PDN, for those who have ventilators or utilize a trach a lot, they would not qualify for this because they would be too acute. But at the same time, the nurses that are working those lower acuity cases can then work at the higher end of their license, working those cases instead. So we can get those cases staffed as well as these. And as Kristen was saying too, I don't know if there's a second here, but I do have a PowerPoint slide that just shows the hospitalizations over the last 2 years compared.
Yeah, you can go ahead and share that. Go
Can I
ahead.
share that, Sean? Okay.
Yeah.
Let me share that real quick. Can you see my screen now?
Yes.
Okay, great. So this is the blue lines represent our 5 offices in Colorado, which do the family CNA or parent CNA, as parents are called, program. Hospitalization, this is not rehospitalization, this just takes in all hospitalizations. So over a 2-year period, as you can see, for our population, and in Colorado, it's 800 children that we're talking about, is in the blue. That's the hospitalization rate. The one in orange for the rest of our 30-something agencies that do private duty nursing throughout the country, that is their hospitalization rate. What the reason for this and what we see is, I ask parents all the time, who are involved in the program in Colorado and New Hampshire, and now in Arizona, and then there's 3 other states that have just started a modified version of it. And you know, what they told me is, you know, hey, we were educated, we knew how to do what we were supposed to do for a child, but we didn't know what you guys did, and we didn't know why you did what you did, like wearing gloves, things like that. And so they became much more of an informed caregiver and consumer. And so they knew what to do when things were going wrong, and when to worry and not to worry. And so that's why you see the hospitalization rate go down so low. And why this is important to point out is not only we don't want children in the hospital needlessly, but also for the states, 40% of the expense, 40% of medical spend for PDN is because of hospitalizations. So if you have 1% of the population that's private duty nursing, 40% of their Medicaid spend is on these kids, and that's because of hospitals.
So Bill, there's a question in the chat from one
Please.
of the Terry Yancey. He's over our community integration healthcare team. He's asking, how does the acuity compare with the 2 groups in this chart?
So that's a great question. So your acuity typically for the kids who are getting this program are lower acuity. So they're going to be G-tube Mickey buttons, so feeding tubes, all the way up to someone who maybe has a trach but has low to moderate needs for that trach. And then the other children that are on that are not getting the service are usually higher acuity individuals. So they could be high utilization of the trach, or fully vented.
Well, and Bill, I would also say it also is going to include some low acuity, because not all families choose this option. So it's a range of lower acuity to higher acuity.
So do you share our concern? It sounds like you're talking about it, that we always are concerned in Texas that no good deed goes unpunished, and they get a hold of it and do over delegation or forced delegation, because that's something we have struggled with quite a bit, and our parents are like, I can't do this, and it makes them have to quit their jobs and things.
Sure.
Yeah.
Sure. So in our bill framework, we have it in there that specifically states that it is a parent's choice,
Okay.
whether for them to participate in this, not, and ultimately it is their choice. Just as they choose to how to work in this model, what kind of care they want for a child, that this should also be a choice as well. So we put that specifically in the bill framework language. So it's always parents' choice. And that's the biggest thing, because we do have parents that sometimes don't want to participate, in this program. That's fine. We have other parents who are overjoyed and want to participate. So it's just, the only way this works though is we got to make sure that the parents, especially mom, is on board and is going to want to do this and feel that this is a good avenue for them. What the reason we're proposing this, as Kristen was talking about, is obviously there's a multitude of issues that are facing home care right now. And so there's not just one way that we have to resolve it. We have to resolve it by not only rate increases, but we have to resolve it on ways that we kind of be a little bit more, that we are better with staffing. And so this is one. But as Kristen was saying too, the other thing is, by paying nursing professors, we have 80,000 potential students a year who can't go to nursing school in this country because we're paying nursing professors $40,000 a year but they're master's level prepared. If they go to a hospital, they're making 6 figures. So they're choosing the hospitals, not teaching. We gotta change that.
No, I'm aware of that. I have a family member that's a nurse, and they were going to go into, they wanted to be an educator, and then it didn't work. It's like, forget
Sure.
it.
Well,
Yeah.
and the other thing too is, Arizona actually just proposed this, and they just started this law where now all nursing schools are required to report to the state annually not only to the governor, but to the legislature, not only how many nurses that they're educating, but if there's any any issues to getting access to, for students to be able to become enrolled, they have to let the legislature and governor know, and the legislature and governor are supposed to do something about it here, increase funding, whatever they need, but get them the resources they need. So that is something also too that the state can do, where these schools can report back to the legislature and say, hey, this is what we need real time. And this is what we need to do that. And I think not only nursing schools, but also as we're talking about CNAs and things like that, and for attendance, those things need to be, there should be a direct line to the legislature, to the governor's office, telling them, real time what we need. Because that's the other issue too. We don't have a pipeline in this country anymore. Our pipeline's been destroyed. Hospitals have really gone after BSNs, like Kristen was saying, and that's destroyed the pipeline. That's destroyed a pipeline of starting someone out as a CNA, then they become an LPN, then they become an RN. And so because of that, we've really destroyed that pipeline. But also scholarships. We need scholarships as well for people to go into directly to this profession.
Bill, if you don't mind, I'm gonna. This is really all of what you and Kristen shared has been amazing, informative, I should say. But we're running a little bit behind.
Sure.
If I could I get a copy of the PowerPoint? Kristen, I'll email you. And
Yes.
we'd like to analyze it. Nancy Crowder, how are you out? You out there, right? I see you.
Still here and still awake.
Yeah, Nancy is with Adapt of Texas, and I want to give them a special shout out. They have been fighting this battle in the trenches forever. So Nancy, I'm going to turn it over to you, and why don't you give us I know your focus is more on the attendant issue, so why don't you tell us about what you're seeing out there?
Well, let me just say good morning, and also to Bill, bless your heart. We would love to see funding for everything. We have taken it to the steps through the legislature and to the governor's door. To no response. And we actually got cited for trespassing into his reception room when we were requesting a meeting about these very issues. It was very peaceful, but that's the type of reception we get. We're adults with disabilities. Most of our disabilities are functional. We direct our own care. Community attendants are not licensed. They don't have to be. I take people mostly who apply for positions that I put out and recruit for. And recruitment has been obliterated since last, I want to say 5 to 10 years. I have personally recruited through ACC, which is 35,000 students on that registry, and not one applied or called or showed any interest. I recruit through my next door, which is a huge community if you add all the surrounding communities. Nobody. And once you put that salary in, whew, it's up in the air. So I don't try not to take it personally, because I'm a really good advocate for attendant services and community attendant services, but because of the pay structure, it just hasn't gone anywhere, and it's putting our lives at risk. I just lost a friend who could not find an attendant, became sick at a nursing home. They couldn't take care of her. She ended up in the hospital with pneumonia. and died. Wow, that's incredible. It should never be that way. I've been working with the Personal Attendant Coalition of Attendants. Again, our focus is on community attendance. We have close to 300,000 people living out in the community with disabilities. And they're doing this by the use of community attendance. And it's scattered. People recruit every which way they can. Some are on programs, some are private pays. Mostly for my situation, I'm on the Consumer Managed Personal Attendant Services, or SIMPAS. There's also the Consumer Directed programs. So we're talking about probably the largest population of people with disabilities living in the community, and the largest population of senior citizens, of which I'm becoming both. So I'm almost dual eligible. Anyway, I wanted to make sure that you know, PACT has been pushing raise it, raise it, raise it for almost 15 years now. We've been in the legislature all the time. No PTSD here, but I know when people aren't listening to us or don't care. And I've seen too much of that. And if we could pull everybody that's right here on this session to come out and say what they want to say, but are afraid to say it. If you could come out and testify to the fact that people's lives are on the line, there are cheaper ways than nursing homes or SSLCs or group homes or whatever, maybe they'll get it. But it just depends on who's lining whose pocket. A couple things I wanted to say is that all the programs need to be able to hire spouses to provide attendant services. Not all programs do that. What a waste. Let's do it across the board. This is nothing new. We've been trying probably for the last year to get HHS to change that or send the amendment to CMS to make that a reality. Wouldn't that be easy? Some of these things are too common sense. Right now, HHS has a survey online. I believe it's good until the 28th. I would really indulge and request and just get everybody who's an attendant, knows an attendant, uses an attendant, to fill out the survey. It's about attendant services. HHS needs to hear more from us, and maybe even louder. Because I can't believe 15 years later, they're finally saying, you know, maybe we should do a survey on attendance. Yeah. Well, it's not really working that well and not as fast as we need it. The attrition issue with the attendance is getting worse and worse. However, the attrition value, I want to say, within these community attendant programs, people are staying alive, they're staying productive, they're, you know, I can't even begin to tell you how much more it means to a person with a disability and seniors to be living in their own homes, directing their own care. So, and now let's get to the attendants. Who are these people? Well, allow me to share my screen.
Nancy, while you're doing that, I'll put in the chat the link to the survey that you're.
Great, thank you. I
Okay.
think everybody's gotten it from here from me, but let me go ahead and share my screen real quick. In our community attendance, can everybody see this?
Not yet, no.
Oh, darn,
Are you hitting a little green
hello, green.
thing at the, and then you gotta hit share again on the actual screen if you see it. See that?
Oh, yeah.
You
Hold
got
on
it.
here. Let me get back to this. Okie dokie.
There should have been something that popped up, says select a window or application you want to share. And then you hit share again at the bottom right. Do you see that?
Apparently not.
Okay, if you,
I do have, skill in this, but
no,
every time I really want to use it, it goes.
it
But
happens,
anyway,
yeah.
yeah, I wanted to say that it's a woman's and a people of colors issue. If you look at the overall population of people who are community attendants, it's a human rights issue. Over 300,000 attendants working with 250,000 consumers with disabilities in Texas. These are all over 18 and up to 99, I guess, folks who are working in the disability and working in the community. The majority of our home and community-based workers in Texas are 88% are female in Texas. They're persons of color, 76% there. The median age, and this was a couple years ago, but the median age is 50 years old. A lot of the people are aging out. And again, starting at 8-11, it's not something we can really jump up and down about. It's hard to recruit anybody, and I have a 20-minute attendance story for you. It's not going to take 20 minutes, but that's how long the attendant was in my house.
Oh, wow.
I recruited her from Houston. She moved to Austin. She came to work with me. I made sure everything was transferred, faxed, signed, everything. And she walks in, she says, "Nancy, I hate to do this to you, but I got a better paying job."
Oh, that's gotta be
Yeah,
hard.
that hurt,
Frustrating, yeah.
very hurt. So we have to understand the struggle of the attendants themselves. A lot of them are on Medicaid services, getting SNAP, etc. Many of them are of lower income. We have folks that are taking these part-time positions to try to fill in for a full-time position so that they can, of course, take care of the single parent home. A lot of the attendants will never see time and a half overtime through the agencies, never, because it's forbidden. And then there's no vacation, no sick leave. You've heard the whole story. This is like the bottom part of the community care programs. And it just, in our heart of hearts, we're going to continue to fight the fight but we all have to come together. We had a great meeting with Jessica the other day, Jessica Boston, and it sounds like we have some real aggressive, energetic possibilities for this legislative session to really collaborate and get the word out again to get our needs across to our legislators. I cannot understand how our legislators can spend a gajillion dollars on a Cadillac and then look at the Ford and say, nah, you know, and it just kills me to see that happen. So with that, I want you to know that PACT and ADAPT are leading the charge continuously, and it's not an easy thing when your life is on the line. So I will leave it at that.
Thank you, Nancy. That's thank you for that information in your story. I'm sorry that you and all of the other members of ADAPT that experience this on a daily basis, and we're trying to do what we can on our end, obviously. But thank you very much again. Laura, I'm gonna have a little change of plans because we're running behind. So no fault of the presenters, me. I've been editorializing too much. So we're gonna skip the last video. We'll put it up on our website or something later if people want to see it. But let's do this. I want to start the open discussion. We may go a little bit over, but that'll be okay for those who can stay on. We've heard a lot of good input today, and I know we have persons out there in the chat that have been asking questions. One of them that came up was, I'm trying to find, I think Jack, is this Frezzy? How am I saying? I'm probably saying it wrong. Jack, are you out there?
It's pronounced crazy. It's like crazy with an F.
Frazee, okay, thank you. Jack, why don't you ask your question? You were asking questions about the MCOs and their role in this.
Well, yeah, I'm just curious, you know, MCOs get paid capitated payments, and presumably the point of that is because they're guaranteeing that services are in place for their members. And I'm assuming when, you know, they're not able to hire someone, they're still taking in these capitated payments. So it just seems to me like that's completely backwards if they're failing to ensure access to care, but they're, you know, profiting from this situation where they're just saying, oh, well, we don't have someone to send to you. That seems to me like something the legislature would be concerned about. And I would guess that the MCOs contractually with the state have made a bunch of assurances about how they're going to provide access to care. So I don't know, it seems to me like they must have a significant role in this. And if they're not performing that role, what's going on there?
So Jack, you're with the Texas Nurses Association. Did I say that right? Nurses?
Yes, the Texas Nurses Association.
Okay. I know we have one of my folks out here, Hillary Garcia. I'm going to put you on the spot. Hillary, you've done quite a bit of work with MCOs to try to navigate these shortages. Could you share any information about what you've been able to talk to them about their role and how they, not all of them, but how some of them have responded to this?
Sure. Some of the MCOs that we've dealt with, more specifically Aetna, has been very paramount in trying to ensure that our kids get staffing. I will say, caveat, that my clients were at the time in and out of the ICU due to just the severity of their condition and the lack of nursing care that they were receiving. So it was cost saving for them to take action to ensure that my client was adequately staffed. But in working with them, they got together with the nursing agency. I think they might have entered into an agreement with the nursing agency based on my understanding of how it worked out to ensure that they were offering a higher pay rate to entice nurses to come into the home, because oftentimes they were finding nurses, but not at the skill level that this kiddo needed, or they were just saying based on the area, there was no incentives for the nurses to drive out to this client's home and provide the care. So the kiddo isn't still not fully staffed, but has a lot higher amount of hours than they had previously, when they had just one nurse working maybe 3 nights a week and not working the full 7 days that this kiddo needed. I would say that working with Aetna, I worked with them on other clients, knowing what they were willing to do, and kind of worked out similar situations for my clients, but it doesn't seem like it's an overall situation for all MCOs or all individuals. Other things that Aetna was willing to explore that some of the nursing agencies were either on board with or may not have been on board with was splitting the nursing services. So working with 2 agencies just to make sure that if one nursing agency was having problem staffing, another might be able to provide a nurse so that the kiddo could get as close to fully staffed as possible. I will say,
So I'm sorry, so that's an avenue of persons we've been able to take on a case by case basis with that particular MCO. But to go back to the original thing, it's not an overall fix. And we still have this issue. And if Peter, if you're out there, Peter Hoffer, one of our litigation coordinators, one of the top persons dealing with MCOs. Peter, we've taken the position and we feel contractually that they are supposed to make sure this happens, that they have the quality of services. But is that where we're still at on that? That it doesn't happen, but if you could comment on that.
Yeah, I think they're still supposed to have adequate network and adequate provider base. What we can do about it, I'm not sure, but that's something we can explore. But we get cases through intake and deal with it on an individual basis, but we need to look at it as on a more systemic issue based on everything we've heard today. But that's certainly an avenue to explore.
So Hillary, have you heard anything about systemically what they're trying to do? Have you heard anything?
none of the MCOs have shared systemically what their plan is. I feel like certain other agencies, like their medical directors, their attorneys don't necessarily get involved. I would say that Aetna's did schedule like a conversation so they can understand what was happening. When I reach out to other MCOs, they say, oh, service coordinators are aware of what the expectation is to provide services, but perpetually the coordinators are telling the families that this is a situation. There's just staffing shortages. Keep us posted if you do receive any updates, and we'll just reach out to the nursing agency on your behalf. But there's not we're going to provide the nursing agency with money.
Yeah, somebody's trying to speak. Who's that out there?
This is Kristen Robinson. From an agency perspective, I would like to share too. So one of the things that Peter had mentioned about network adequacy, that I know that the Texas Association for Home Care and Hospice had tried to request from the state was, I think it was for a 5-year period of time, looking at the authorized hours versus the billed hours, so that we could see the trend in the decline in access to care. And HHSC essentially said that they could not get that data. I know from working with the MCOs, whether it be around value-based agreements, single case agreements like she referenced, that is definitely data that the MCOs have, and that would show whether or not they actually have network adequacy when it comes to a specific service. So whether it's therapy or, well, therapy is a little more tricky, but whether it's attendant care or it's nursing services, those hours are authorized and they know what's being billed. So they know what their utilization rates are. And I will say, yes, Aetna has been one of the plans that has been excellent at trying to address these issues. We've had other plans that in response to our requests, whether it be for value-based arrangements or it be single case agreements for these children that are, have been looking for staffing forever, is that they are waiting on HHSC to do something this next session. And so I think that a lot of the MCOs are just hinging on HHSC and the legislature coming up with some wonderful rate. And they're holding off before they do anything. But I think too, we see the profit margins that these MCOs are, working within. And if they exceed those margins, they're giving money back to the state.
Right.
So I do, know that with some of the plans, we are seeing them step up. But whether it's across the board, I don't know. And, but it's a lot of money. It's very expensive to do the right thing and make sure that the rates are where they need to be to actually get nurses through the door.
Well, I know we can get the utilization data, and I know they keep it because we've gotten it in the past, because at least 15 years ago, we know that they were authorizing more hours than they were getting billed for. So they were never providing all of the hours that were authorized because of the shortage has been going on for decades. But it's probably gotten worse. But certainly they have that data and we can try to get it.
Yeah, I know that TAC actually, submitted payment and everything for for that request for information. And it took a very long time, but the response that they got back was that they did not have it and could not get it at this time. So would love for others to try and get that data for sure.
I'm sorry, I just want to ask a clarifying question. Are you saying that the state is saying that they personally can't get access, or that the MCOs don't have the data? Because the MCOs definitely have that data.
I know the MCOs have the data. It was HHSC saying that they did not have the data.
Which means they didn't ask for it.
Yeah, this is Elizabeth. The Star Kids Advisory Committee has asked for that data for years, and the HHSC keeps saying it would be too difficult to get that data because they'd have to collect it from each of the MCOs. And so that's problematic. We get the data on the number of children who are getting private duty nursing, or the number who are getting a personal care services or CFC, and the number of hours paid. And we've seen the number of hours paid being dwindling down as of late. But I think the other big telling thing is that the state collects financial statistical reports from all the MCOs across all of the different programs every year, and that they have failed. The last one they posted was like FY 2020. They have not posted 2021, 2022. That is already closed, but the data that's in FY 2022, because I've seen it through an open information request, public records request, is phenomenal. MCOs making buku profits, somewhere in Star Kids, sometimes up to 24%. And so it's a real issue, but I think we need to demand that HHSC put those FSRs on their website, because they've not done that. And I don't understand, they've got it, but they've not put it on. There are a couple other things that we've had a 22% increase in children going into nursing facilities in Texas over the last 6 months. Have never seen it.
Elizabeth, this is Elizabeth Tucker with Every Child, a good friend of ours. And I just wanted to tell everybody who you were. I was about to call on you about the 22% increase.
Yeah, 22% increase. Children and young adults under 22 going into nursing facilities, some from other states, some from Texas, anywhere from the age of 3 to 2 to 0 years old, up to 21 years old, can't get the nursing that they need in their homes, even though they've got Medicaid, can't get attendant care. Some of them have families that don't want to provide the care, even if they could receive payment. We do believe that we should really look at the family caregivers, fully support the spouses being paid, fully support parents being paid. There's a way to do that. And we've got information from HHSC after they've investigated all this for Star Kids on how that can happen and what needs to happen to allow that. Texas, bottom 5 states that for attendant care wages. The median, in 2020 for the United States was $13.56. What are we at? $8.11 or something floor. We're in the bottom 5. It's ridiculous. People can't get attendant care. People need attendant care. And so we've got to do something about that. And then there's also the Texas Center for Nursing Workforce Studies. Why aren't we asking them to do a study of wage disparities? That's over at DSHS. I really think that we've not utilize them like we should. I know that they just did a survey with home home care and hospice. I don't know what that survey, the results of the survey, but I think we need to look at that. And I really believe we've got to have a mid-tier workforce. So there's a lot of work that needs to be done. The Policy Council for Children and Families has got all of our recommendations, including increasing the attendant care wage to $15 an hour, allowing for the parents as CNAs and the other, I think not just parents as CNAs, I think we need a CNA program, and allowing what Kate Chappell said in her video, Texas HCS needs to allow family caregivers, whether they live in the home or not, and the spouses and parents. So there's a lot of work that needs to be done. And I think that there's momentum. I don't know how to push it further, but I really encourage us to try to get that HHSC to post those FSRs because they're telling, very telling.
And that's, I didn't know about that. Okay, I'm writing my notes here. So does anybody else have anything that you want to share or ideas or before we move on to next steps?
This is Angela, and I just wanted to share that I had posted a link to the Rev Up event that's at UT on the 19th of September at the AT&T Center. You can also stream it. That is a Meet the Candidates event. So a lot of the things we've been discussing are things that the legislature might have to address. So that's your first place to begin influencing that particular aspect of Texas.
Okay. Diane's got to step away. Thank you, Diane, for participating. What I want to just say, so next steps, obviously we need to make this an issue. Again, I've seen and we've all seen a ton of money go, particularly throughout COVID, to hospitals and other places, but this particular community, really not much was done. A little bit with PPE and things of that nature, but not really, not to address these issues. And these issues have been around for quite some time. They're just being exacerbated. We want to obviously make this an issue that the public is aware of, because I don't think people in the general public really think about this unless it's affecting them. And then the big ask I have is, how do we come together? How do we take this knowledge and make a collaboration to come up with some policy recommendations for these these policymakers? And what do we think does that process look like? I mean, do we want to make a work group out of this that we can meet and share information and come together? So I want to throw that open to the floor. Again, I don't have the answers to this, but I just wanted, I've talked to a lot of you all individually, or my folks have, and I've heard this piece and this piece, and I want y'all to get basically in the same virtual room and I know some of you've already done this, but to come together and get some kind of a coordinated effort towards this. So does anybody have any input on that? The idea of a work group or something coming out of this? Nancy.
And Nancy Crowther with the DAP. You know, we have been individually, I would guess, beating this over their heads for years. I really don't want to get into another committee.
Gotcha.
Can we just pull our stuff together and present it? And it'll be such a repetitive thing. Jessica, I don't know where you are, but we had talked about trying to have some type of an introductory to the legislative staff that says, here are the issues. Oh, there you are, Jessica.
Yeah, she's there.
Yeah, she's there. And Jessica, if you want to, speak to this, I think we were in agreement that not a lot of people understand or are listening. So I'm going to go ahead and let you take that on. But that would be my suggestion.
Sure. So yes, Nancy and Kathy and I have been meeting and having ongoing conversations. And one of the sort of ideas that they brought forward that we echoed as a great idea is that we're really looking to the next legislative session. We're going to have a lot of new members. And while educating members is always a tremendous goal of our advocacy work, I think it will be exceptionally important as we go into the next legislative session. So we talked about doing having an open invite to legislators and staff at the Capitol to do an education session and sort of have an overview, introducing our key issues, and also kind of starting from the beginning and explaining what these services are, what are the programs, where do they take place. Obviously, there's a lot of expertise on this call here and would love to have support in putting that together, but we talked about doing that very early, possibly December, maybe even January at the latest, so that we can really start the conversation as early as possible after elections and the dust settles and we kind of have a better idea of what we're looking at for the legislative session.
Okay. I think that could be very helpful. What do you, Nancy, is that what you're thinking about? Okay. All right. Anybody else?
And Sean?
Yeah.
Yeah, Sean, this is Carol Smith. I think that would be a great idea. I do want to just say that, and I know someone kind of noted this in the chat, I mean, the rates across the board for the various programs are different. There's no doubt about that. But they're not all that different in terms of what's built into some of those wages. And I just think through this process, we don't need to pit each other against each other. We need to be united on what is needed across the board for attendance. And that would be my hope that we were able to do that, because if we go down there and fight and go, well, my program's more important or whatever, that will not be effective either. So
That's a very good point. That's a very good, that they kind of play Hunger Games with us, don't they? Just kind of throw out.
They do. And
Yeah, right.
that's why I apologized earlier. I never should have brought up what was going on right now, the state supported living centers, because that's not an effective argument either, you know, that we know how that has turned out before. So, but at least for all of us, you know, our services, all of the services that either some of us provide or we represent people that provide it, or we have people on here that are depending on these services, we all are in the same boat, and we need to be very, very united on what our ask is.
Okay, I agree with that. So one thing that's come out of this is I think we now have and I can share it with you if everybody's willing to share a database of everybody on here, so we can keep talking and working on this. And we can, at DRTx, we can try to keep this going and organized to some extent. I probably maybe what we'll do is we'll reach out to some of you individually to kind of get what you think, because I know it may be easier than trying to do all this at one thing to see like how we can do next steps. I know we're already working on stuff on our end, but we're way over. And but I think this has been very helpful for us and to put a face on it. And we have people leaving. So let me do this. Unless anybody else have anything?
Sorry, this is Jack Frazee. I don't want to belabor anything or drag this on too long, but I just want to say one thing that we're focused on at TNA right now, just kind of hyper focused on, is the workforce. And I don't think I have been fully aware of how much this is extended to long-term care. So I would very much like to assist with the work that y'all are doing. So please share whatever information you have with me. If you don't have my contact info, I'll put it in the chat.
Yeah, could you put that in the chat? Because I don't think I have it. That would be great. Okay. All right, anyone else? We're gonna again reach out to everybody again. And we have another organization that we've worked with. It's the Texas Partners for Inclusive Access. It has a bunch of groups like TCDD, CTD, the architects, is quite a bit of them, and they work with us on a variety of issues. One of our big projects was making sure that persons with disabilities could get access to the COVID vaccine. That was another big thing we've done. And we had quite a bit of success with that. What we've done differently with that particular project is depending on the initiative. We have worked with, to be frank, sometimes as folks we not necessarily adverse with, but we didn't really work with them on particular issues. So we do public and private partnerships, strategic partnerships, best way of putting it. What we may do is we're thinking about doing some stuff with that particular group as far as getting this message out. But one of the things we found is that by sharing our networks, we have been able to get by a force multiplier, getting the message out to more persons about this is an issue. It was highly successful with the vaccination issue, and I think we could do something similar with that. So on our end, just real quickly, DRTx, we're still going to working out what we're going to do. But one thing I can assure you that'll come out of this is we will be reaching back out to everyone. And if I don't have your, and Laura put up the client videos, I'm sorry we couldn't show them all, but I don't want to keep you. So if you want to look at them, there's a link. But if we will be reaching back out to you and thinking about next steps and how we can harness this energy and come together. We're on a somewhat of a short clock. This is a very important session. I think for this issue, maybe one of the most important sessions we've had. And we're hoping there's an opportunity here. So if anybody, unless somebody else has anything, feel free. Going once, twice, 3 times. Thank you so much. This has been wonderful. Thank you for your participation, and we'll be reaching out to you again. Thank you so much. Bye.